So I just want to start this part of the lab with your page 142, I believe. If I'm wrong, please check it out. And we talked about some of these values like PO2 or PaO2, same thing. And then your SaO2 is your oxygen saturation and hemoglobin. So if you see SaO2, it's going to mean that we used an arterial blood gas. If you see SpO2, it's going to be the pulse oximeter or peripheral pulse. CaO2 is the important value, and that takes into all the hemoglobin that's in all the oxygen in milliliters in 1 deciliter of blood. So these are the conditions. Now, of course, in any of these, your CaO2 is going to be low. So your severe anemia, carbon monoxide poisoning, severe VQ, either way. So below 0.8 or above 1. And then high altitude is going to decrease your CaO2. So the anemia can be normal with partial pressure of oxygen because it has nothing to do with the partial pressure of oxygen. And it just has lower hemoglobin, which can give you a normal saturation of hemoglobin on the saturation of oxygen. Carbon monoxide, you could have a normal partial pressure of oxygen. You just can't use that oxygen. So your SaO2 is going to be decreased because hemoglobin has a higher affinity for carbon monoxide than it does for oxygen. So you could have a normal PaO2, but you can have, of course, a decreased SaO2. Now, SpO2 could be normal, and it is normal with carbon monoxide poisoning. And we're going to go through that again on this recording. Severe VQ, all decreased. All decreases. This is the amount of oxygen coming in or being perfused, ventilation and perfusion. So all these values are going to be decreased. High altitude, you have a lower partial pressure of oxygen right off the bat. So that's going to decrease all these values. Pulse oximetry. Now we're going to start with the SpO2, which is the use of the pulse oximeter. Now, if you go on page 141 in your lab manual, you want to memorize these normal values, like the normal saturation of oxygen, percent of hemoglobin, percent oxyhemoglobin, so overall hemoglobin should be between 95 and 100%. The PaO2 or the PO2 should be around 100%, about 100%, 100 millimeters of mercury. The CaO2 should be between 16 and 22 milliliters of oxygen per deciliter of blood. And the hemoglobin values, males 12 to 17 grams per deciliter of blood, grams of hemoglobin per deciliter of blood. Females 11 to 16 grams of hemoglobin per deciliter of blood. So when we do CaO2, you'll see there's other values which we have to memorize. So this is the pulse oximeter that you could buy. Put this on your finger. It'll give you the oxygen saturation on the hemoglobin. That's the 97%. You see the pulse rate, which should equal the heart rate, 72 beats per minute, and actually can show you the waveforms. This is showing you the waveforms in this oscillator at a heart rate of 64 beats per minute. And of course, gives you the oxygen saturation on hemoglobin percent. Here's another version of that. Looks like it can be manipulated to see different things like the pulse rate and others. So we talked before about pulse, and pulse should equal your heart rate, but pulse is a palpable feeling, or you could feel the systole. Like if you do a pulse on somebody's apex of their heart, they call that the apical pulse, where you palpate between the 5th and 6th intercostal spaces right around the mid-axillary line. So you'd have to bend the person forward and to the left. So that's actually left ventricular contraction, right? You can feel that systole. And then you can go peripherally and feel the radial pulse, the thumb side. Remember, always use your second and third or index finger and middle finger or ring finger. Don't use your thumb to palpate pulse because it has its own pulse. And what you're feeling is these waves Could you guys see this white arrow at home? Paula, can you see this? Anybody home there? Amelie, can you see this white arrow?
Yeah.
Oh, thank you so much. So the pulse oximeter is really measuring this red blood. This is arterial blood, right? So it's you could see the pulsations. And you should have at least 5 seconds or at least 5 pulsations for the pulse oximeter to get a reading through arterial blood. So very important. The pulse oximeter is not testing venous blood. That 95 to 100% saturation of hemoglobin with oxygen has to do with arterial blood only. Not talking about venous blood, because venous blood can be 75% saturated. That's completely normal, but we're talking about arterial blood. So the heart rate we can get from the EKG, we could do the RR interval, the 300, 150, 100, 6-second strip. And apical pulse we could do. It's not that easy. You could feel that if the person is thin enough. And then peripheral pulse is really what we're feeling with our fingers. And that's what the SpO2 is. That's what the pulse oximeter is testing, the peripheral pulse, all right? Not the apical pulse, of course, or the heart beat. So these are the reasons you have low pulse rates or no pulse rates on the pulse oximeter. Now, if you tried the pulse oximeter in here and you didn't get a pulse number, it's okay because something was wrong with that pulse oximeter, or we didn't calibrate it right. But you could see the pulse waves on it. It was pretty good. And you could definitely see the saturation of oxygen, of hemoglobin with oxygen. So these are the causes of less pulse waves. And hypoperfusion means there's less blood getting to that peripheral tissue, like from severe vasoconstriction, right? Certain medications cause sympathetic responses. Hypothermia and sympathetic nervous system activation, which can cause systemic peripheral vasoconstriction. So you might not get those peripheral pulse waves, and you might not be able to use the pulse oximeter in those situations. Heart failure, or the shocks like hypovolemic shock or cardiogenic shock, can create a low pulse activity at the peripheral area, like the finger. Of course, breaking a bone and you're not getting blood to that tissue is an obvious thing. Sometimes the nurse or the EMT or the doctor will tape the pulse oximeter too tightly, so that'll constrict the arteries. And sometimes you have excessive pulsations, and that would give you more of an artifact, right? Like shivering or muscle contraction, seizure in the event of a myoclonic seizure where you're contracting your extremities. So that will give you a false high reading. Parkinson's disease with the no release of dopamine from the substantia nigra can give you a resting tremor, which is kind of like an artifact. So that gives you extra pulsations. And it'll be recorded aberrantly on the pulse oximeter. Sometimes if the venous blood is engorged, like normally you don't have high pulse waves in the veins, peripheral veins like this, but if there's some engorgement where the venous blood can't get out of that region, then you're going to get extra pulsations that are going to compound the arterial pulsations. So you might get ridiculous numbers when your pulse rate is really 82, but it's showing 220, something like that, because the veins are causing that artifact, right? So again, heart failure, of course, especially right-sided heart failure, which causes back up into the systemic veins and systemic edema, like I mentioned before. And this is the hemoglobin saturation curve. Again, you know this from lecture, and we'll go through this on a couple of different charts. So this is the curve here, and you can see the steep region is where hemoglobin has a low affinity for oxygen. It's dumping off the oxygen. Up here, the plateau, it's got a very high affinity for oxygen. This is coming out of the lungs now, right? These are the systemic arteries here. Around here is the systemic veins. But remember, with pulse oximetry and arterial blood gas, we're testing the arteries for the hemoglobin saturation of oxygen. And over here could be more in the working tissues, like the muscle tissues that are using up and consuming a lot of oxygen to make ATP. So remember, the saturation is a percentage, right? So this one would be, out of all these hemoglobin molecules, 0 are saturated with oxygen. So you have 0 oxyhemoglobin. Half of them in this one, half of the sample of 16, say, have oxyhemoglobin, or oxygen saturated to hemoglobin fully. So this is not good, 50%. It's never 0%. And this is the arteries, don't forget. This is 75% oxyhemoglobin to all the hemoglobin. So this still is not good for the arteries. It's normal for the systemic veins, but 75%, remember, is probably going to be cyanosis. 75%. All right, so 75%, around 40 millimeters of mercury PO2. So this is like kind of a cheat sheet, which I'll give you, to see the partial pressure as it matches up with the oxygen saturation. So 100% means that all the hemoglobin, these 16, and this is just a sample showing you, this is not the way it is, 16 molecules of hemoglobin, all of them are saturated with oxygen. Every one of them is fully saturated. So you just basically, the machine is doing this. You're not going to have to do this. It takes the total number of hemoglobin molecules in a deciliter of blood, say. We're just saying that arterial blood gas does that. But in the pulse oximeter, just taking that peripheral sample for 5 seconds or 5 systoles. And then how much of that total hemoglobin is oxyhemoglobin? And you get a percentage, which is a 0.87 times 100, of course, gives you the 87%. So go through this and do this in lecture. I'll go through what this means later, these numbers on this right axis here. So like I said before, at 100% or 100 millimeters of mercury, sorry, and above 95% oxygen saturation of hemoglobin, this is what the systemic arteries should be like. And it's totally appropriate because we're delivering oxygen to the tissue, right? Starting with the brain. Okay. So this is high affinity for oxygen. So hemoglobin has a high affinity up in this plateau. Now, as it's dumping it off into the tissue, which is completely appropriate, to have a low affinity for oxygen from hemoglobin. So in the tissue where the veins are coming back from the tissue, you have a 75% oxygenation, but we're not measuring that with pulse oximetry. We're not measuring that with arterial blood gas. We're measuring the oxygen that's in the arteries, because that's the delivery system to the tissue, right? And over here it'd be much lower, low partial pressure of oxygen and a very low saturation of oxygen on hemoglobin. This would be in your cells that actually lost the oxygen and the Bohr effect, right? You learn that in respiratory. This is Dr. Menon's class, right? You've been doing respiratory for a couple of lectures, so hopefully matches up pretty good. This is the cheat sheet that I showed you before. I kind of mentioned before also, like if you have a below 95, like a 93% saturation and a 70 millimeter of mercury PO2, this is too low. This has to be either assisted oxygen or keep monitoring. And if it goes to 60 millimeters of mercury and 90% saturation of hemoglobin with oxygen, that's the ICU point, where we want to prevent going down to 40 millimeters of mercury or 75%, which could be cyanotic. So you don't want to wait for cyanosis. Like we used to do that before the pulse oximeter, actually. You'd wait around to see what they look like before you would use assisted oxygen or put them in an respiratory ICU. Yeah, so this is cyanosis, and this kind of explains that. On the SO2, remember SO2 is the same as SaO2 and SpO2, but we've already decided that it's a correct saturation. Like we don't have to deal with, well, is the pulse oximetry was normal, but is there carbon monoxide poisoning? Is there hypomaglobinemia, sulfhemoglobinemia. So if it says SO2, that's the saturation of oxygen. So we decided we're going to live with that. Okay, so again, this is talking about comparing it now to the PO2, partial pressure of oxygen. And PO2 is the same as PaO2. You might see PaO2. It's the same thing. There's no difference in that, no difference in how we got it. This is the arterial blood gas and how it's done. Again, you can't poke a vein here. You have to take blood from an artery because this is an arterial blood gas. If you want to find out the absolute amount of oxygen in this blood, and that's deciliter of blood, whatever you're taking out, and the machine is going to measure that. There's also a co-oximeter involved that can tell you the different gases that are binding at the same wavelength on the pulse oximeter versus the arterial blood gas. So before we mentioned what's the good things or the positive things about using the pulse oximeter thing you put on your finger, SpO2, is that you can monitor a person constantly with their pulse and then their SO2 or SpO2, which is the saturation of hemoglobin with oxygen. But the problem with the SpO2 is that it's absorbing other gases at the same wavelength, which I'll show you. Arterial blood gas is more invasive. So you have to poke somebody, of course, and you're only getting a moment in time when you're doing the arterial blood gas. You're not monitoring. You can't keep monitoring by keep poking, right? So SO2 is what we agreed on. That's the number. We know it's not coming from anything else. It's the amount of oxygenated hemoglobin or oxyhemoglobin in that sample. SpO2 means we got the sample from the pulse oximeter. SaO2 means we got it from the arterial blood gas. That's the only difference. So know that SpO2 is peripheral pulse oximeter. SaO2 is from the arterial blood gas. Okay, so of course the arterial blood gas is going to rule out all the other problems through co-oximetry. So again, remember the light or the LED, the light emitting diode, comes from the top to bottom. The sensor is going to be on the bottom. So these pulse waves, these high pulse waves, systole, and the arterial blood is what we want to absorb that light within. So anything that reaches the sensor on the bottom of the pulse oximeter means it wasn't absorbed in the blood. Okay, and I'll show you that again later. This is just going back to that same percent of oxyhemoglobin within a total sample of hemoglobin. 87% is not good. Right, so we're going to look at two different wavelengths. Pulse oximeter is going to use two different wavelengths. One is infrared, and infrared is about 920 nanometers. So oxyhemoglobin absorbs infrared light. So the more infrared light that's absorbed in that hemoglobin sample, the more oxyhemoglobin is in that sample. So you got to memorize the 920 nanometers. Red light is 660 nanometers. So free hemoglobin or reduced hemoglobin will absorb red light at 660 nanometers. So that's important to remember. And here's how it works. Basically, the light will go from the top to bottom, and the arterial blood will absorb at two different wavelengths, at 920 and 660. And whatever doesn't reach the sensor is being absorbed by the blood. So hopefully you have a 95 or greater % of infrared light being absorbed at 920 than you do at 660 of that total hemoglobin sample. So this is just showing you, just go through these and see that, like, the different percentages. I'm not going to ask you about these little bumps in this hill, but make sure you know that the light comes down from the top, the LED, it's absorbed on the bottom, and the two wavelengths that both absorb at. So you can see this is looking for free hemoglobin because it's absorbing more red light, which is not what we want, right? So again, same thing. This is absorbing red light. This is absorbing infrared light. So you'll have a higher amount of infrared light. But you have to, the machine takes both of them and then gives you a percentage. You don't have to figure out the percentage on a pulse oximeter. This is a lot better, right? If you put them two together, you add this plus this, you'll get the total hemoglobin absorption. And then the machine will tell you the percent of oxyhemoglobin to all the hemoglobin. It doesn't tell you the percent of oxy to deoxy. It takes all the hemoglobin and gives you the percent of oxyhemoglobin in the arteries. Remember, this is arteries. Always the arteries, right? So again, the pulse oximeter, SpO2, is taking the total hemoglobin and giving you a percent of how much oxyhemoglobin is in that sample. So that sample should show 95 or greater, 95 to 100%. Okay, and this is, let me just make this slideshow, okay. So this is just showing you, again, breaking it down, 50% of that hemoglobin is oxyhemoglobin, 75 and 100. So what is this one? This, if you add these two together, they're both giving you the same amount from each wavelength. So red is 660 nanometers, infrared 920, oxyhemoglobin absorbs the infrared, free hemoglobin absorbs the red. So you have 50-50. So that's this would be 50% oxygenation. That is not good in the arteries, systemic arteries. So this is that 50%. This one's a lot worse. This one, better. So this one is probably more like the 87%, which is still not good. But you can monitor that. You can monitor the moment to moment, hour to hour oxygen saturation, as long as you know that there's no carbon monoxide poisoning or the person is not anemic. That's the other reason why the SpO2 pulse oximeter has its drawbacks. Because if you have low amount of hemoglobin, but you still could have what hemoglobin you have is highly saturated, it's going to give you a good reading, but you still could be in respiratory distress, which you'll see. So this is the 50-50, makes sense, just so you understand the percentage. I know this is very repetitive. So later on, we're going to take into account the actual hemoglobin number in grams per deciliter. Remember on page 141, tells you the normal hemoglobin value. So 15 is kind of good for both males and females, kind of in the middle, where 10 is low for both males and females, hemoglobin number, right? I mean, you'll do a CBC, so you don't have to do an arterial blood gas to get your hemoglobin levels. You do hematocrit on the complete blood count, and you get the amount of red blood cells, you get the amount of hemoglobin, right? And iron if you need it. And that could be a value you could use from the CBC, and then you match it up with the arterial blood gas, which is giving you the content of the oxygen, or other gases through co-oximetry. So this is, I'm going to talk about this later on this axis to the right here of the curve. This is going to be called your absolute content of oxygen in your blood, and that's the CaO2. So your CaO2, like we said at the beginning, should be between 16 and 22 milliliters of oxygen per deciliter of blood. So this is just showing you at a hemoglobin of 15 versus at a hemoglobin of 10. 15 is normal, 10 is low. And if you have a normal CaO2 of 16, that means your hemoglobin is 15. Over here, if your hemoglobin is 10, it drops dramatically. So small drops relatively in these numbers of CaO2 can create a very large loss of oxygen carrying capacity in your blood. So that's really important. And this is 50-52. I don't know why we keep showing these. So these are some of the terminology you should know. So this could be hemoglobin H, like free hemoglobin, reduced hemoglobin with the hydrogen attached. So this has no oxygen, or it's not fully oxygenated. So remember, like I said before, we're never at 0%. hemoglobin saturation of oxygen. At the lowest, we're like 40. But in a normal person, 75% oxygenation of hemoglobin, the saturation of hemoglobin with oxygen, 3 of the 4 binding sites are bound to with oxygen on the hemoglobin. So that's still a lot of oxygen on one hemoglobin. That's in the veins. That's normal. In the arteries, it's got to be 95 to 100. So most of the hemoglobin you have should be oxyhemoglobin, right? Because it just came back from the lungs to the left atrium, left ventricle, and into the systemic circuit. So oxyhemoglobin is fully oxygenated. Reduced hemoglobin is really still 75%, unless you're in a normal person. Now, if you're in respiratory distress or you have a very low amount of oxygen in your body, whether it's perfusion, ventilation, or some carbon monoxide poisoning, then it's less than 75%. In a normal person, free hemoglobin should be around 75%. In the veins, in the arteries, it should be 100% oxyhemoglobin. Carbaminohemoglobin, because 23% of the carbon dioxide in your blood is carried on hemoglobin, we call that hemoglobin carboxyhemoglobin. So carbon dioxide doesn't bind to the heme part, the iron. Carbon dioxide binds to the globin, right? The amino acid part, the protein part. That's why they call it carbaminohemoglobin. So we have to watch the levels of carbon dioxide. When we do acid base, you'll see that we have to key on acidic blood being high in carbon dioxide, respiratory acidosis. CO is carbon monoxide, 1 oxygen. And this is hemoglobin has a much higher affinity for CO than it has for O2. So hemoglobin bound with carbon monoxide is called carboxyhemoglobin. So basically the carbon monoxide chokes the hemoglobin and stops oxygen from binding, the oxygen gas. Methemoglobin is a reduced form of iron that changes the binding capacity for oxygen on the hemoglobin. We don't have to go into this deeply, but you'll see why this is important. And self-hemoglobin, or self-hemoglobinemia, or methemoglobinemia can decrease your oxygen carrying capacity because of the binding issue of those 2 chemicals. So this is what happens with methemoglobinemia, where the iron is further reduced to 3+. So that changes the color, changes the binding capacity for oxygen. So this is not cyanosis. This is just purple color skin. Your blood is basically taken over by this color hemoglobin. So it's a problem with the hemoglobin, really. She doesn't look like she's in respiratory distress, but I bet you her CaO2 is a problem. Methemoglobinemia, which is this problem in the blood with the reduction of iron. Carbon monoxide is more important as far as the binding, more common, of course, because cigarette smoke. Cigarettes, when lit and smoked and brought into your body, contain carbon monoxide, as do furnaces and car exhausts and old generators and other areas where that gas is abundant. So hemoglobin has a higher affinity for carbon monoxide than it does for oxygen, which really puts you in respiratory distress. Now, here's the problem with methemoglobinemia, or methemoglobin, self-hemoglobin, carbon monoxide. All of those gases, when bound to hemoglobin, will read on the pulse oximeter infrared absorption, or 920. So if you're going through a carbon monoxide poisoning binding, your pulse oximeter is going to look normal at 95 to 100 and probably closer to 100. Same thing with methemoglobin and self-hemoglobin. So this is a big downfall to the SpO2, pulse oximeter, because you could have carbon monoxide poisoning, methemoglobinemia, and self-hemoglobinemia, and the absorption in your blood is going to be infrared 920, which is the same as oxyhemoglobin, because the pulse oximeter only reads and absorbs those 2 lights. those two wavelengths, 920 and 660. Infrared 920, red 660. Okay, so that would be a false high reading. So, and they can compound each other, you know, at that same infrared wavelength. So with the arterial blood gas, you could run the machine into, or you run the blood through a co-oximeter, which will break down each gas. But you can't do that with the pulse oximeter. You have to do it through an arterial blood gas using a technique called co-oximetry, which will tell you each of those gases and confirm the carbon monoxide poisoning. But of course, you have to look at the patient too. I mean, methemoglobinemia, that's kind of rare. I mean, of course, if the person looks like an eggplant, you know, and they're normally, they have a different complexion, it looks abnormal, then that's different. You know, that you know something is wrong. But if they're in respiratory distress and otherwise look normal, you have to watch out for carbon monoxide poisoning, which is more common. Or even if they just smoked a cigarette within the last few hours, and then they have their pulse oximetry done, and they're in respiratory distress, it still may show normal. And really, and this is showing the co-oximeter. You don't have to memorize all these wavelengths and all that, but everything except for free hemoglobin is going to absorb at 920, like oxyhemoglobin, carboxyhemoglobin, methemoglobin, and self-hemoglobin. So the other big problem with using the pulse oximeter versus the arterial blood gas is anemia, right? That's the one you really have to watch out. And that's why it's important that you get that hemoglobin number. Make sure it's between 12 and 17 or whatever, male or female. So this is just showing you, you know, just by changing the amount of hemoglobin, the CaO2, how much oxygen carrying capacity you have. So CaO2, that's the absolute amount of oxygen in 1 deciliter of blood. So that's taking into account the hemoglobin amount. It's taking into account how much 1 gram of how much oxygen 1 gram of hemoglobin can carry. It's taking into account the oxygen saturation that we got. And on the other side of the equation, it's taking into account the partial pressure of oxygen, the PaO2. Then it's taking into account the solubility of oxygen in the plasma, because this is every bit of oxygen we can get in 1 deciliter of blood being measured, and we could do the equation. So we know that 98% of all of the oxygen in your blood, especially arterial blood, of course, is carried on hemoglobin. Less than 2% is dissolved in the plasma, right? So, but we do have to account for that small amount just to get the absolute number. So you have to add 2 sides. One side of the equation of CaO2 is the oxygen that's carried on hemoglobin in milliliters. So oxygen amount or volume is measured in milliliters. And then the other side is the solubility in 1 deciliter of blood. Deciliter seems to be the usual unit, or how much blood we're measuring, whatever solute it is, or whatever volume we're looking for. So CaO2, very important. And this is showing you, like I showed you before, you have normal blood levels. Your hemoglobin is 15 grams of hemoglobin per deciliter of blood. So if your saturation is okay and everything adds up right, then your CaO2 is going to be normal. And you do the equation, if you come up with 20.4 milliliters of oxygen per deciliter of blood, that's within normal range. So CaO2 has to be between 16 and 22 milliliters of oxygen per deciliter of blood. This one is showing you anemia, which has a hemoglobin level of 10. So if you do the math on this one, ultimately you're going to come up with a CaO2 of 13.7, which is below 16. 13.7 milliliters of oxygen per deciliter of blood. So that's anemia. So of course, this is respiratory distress. This is low carrying capacity of oxygen between your blood and between your red blood cells and your plasma, I should say. This is polycythemia, which doesn't really increase your carrying capacity. I'm not going to give you this one to do because this doesn't really help. This just increases the red blood cell number. So your hemoglobin goes way above, normal. But that doesn't mean your oxygen carrying capacity is always better. Plus the things that happen on top of that, like high blood pressure with increasing total peripheral resistance, right? Because the viscosity of blood will get higher, right? So again, this could happen in COPD because you're low in oxygen. So your kidney is going to secrete EPO, erythropoietin, to have the red bone marrow, target the red bone marrow to produce more red blood cells through erythropoiesis. And the same thing can happen if you're at high altitude. Because at higher altitudes, we're at sea level. So at higher altitudes, the partial pressure of oxygen decreases. So that also stimulates the release of EPO, erythropoietin, to target the red blood cells to make more to target the bone marrow to make more red blood cells through erythropoiesis. So I'm going to give you anemia, though, low hemoglobin levels, low hematocrit. So here's the equation, CO2. And the units for CaO2. The units for CaO2, absolute content of oxygen, is milliliters of oxygen per deciliter of blood ultimately. So you're taking the hemoglobin attachment of oxygen, the carrying capacity, and you're adding the dissolved oxygen in 1 deciliter of blood, okay? So here's a number you're gonna have to memorize later. 2 numbers, actually, in this total equation. So hemoglobin is gonna be that number, hopefully between 11 and 17, right? Hopefully 15 is good. And hemoglobin is in grams per deciliter. Then you're gonna multiply how much oxygen in milliliters that 1 gram of hemoglobin can carry. So you have to memorize this 1.34 as hemoglobin's oxygen carrying capacity, 1 gram of hemoglobin's oxygen carrying capacity. Then you're going to multiply the SaO2. Remember, SaO2 is the saturation percent of oxygen on hemoglobin, as determined by the arterial blood gas in this case. So that is going to be a decimal if it's below 100. That's a decimal, not a whole number, percent. So then you're going to do all that math of multiplying those 3 numbers together. And then you do the other side of the equation. And you'll take the PO2 or PaO2, that's exactly the same thing. And that's a whole number because it's millimeters of mercury. So hopefully that's above 60 or at least above 55. And then you multiply the solubility coefficient of oxygen in 1 deciliter of blood. That's milliliters per deciliter. So that solubility coefficient is a very small number, but you have to know it. So this is another one you have to memorize for the other side of the equation, the 0.003 milliliters of oxygen per deciliter of blood that can be dissolved in the plasma. So it takes absolutely all the oxygen you can get in 1 deciliter of blood and gives you this CaO2. Okay, and here's the equation, what it should look like, what you should memorize. I think this is the best one to memorize as you're going through this. So again, this is the first thing you should know is that the units for CaO2, which is the absolute content of oxygen in 1 deciliter of blood. So it's milliliters of oxygen per deciliter of blood. And here it is again. It's basically plugging in the numbers. That hemoglobin hopefully is around 15. The SaO2 hopefully above 0.95. And then you go to the other side of the equation, the PaO2, hopefully it's close to 100, which would be 100, right? 100 times the coefficient, the solubility coefficient, which is 0.003. And ultimately, you get the units, milliliters of oxygen per deciliter of blood. And that's the absolute content of oxygen we can get. And of course, you're going to need all these values. Right? This is just showing you. Definitely do these equations. I did them before. Let's see if we can do them right now. We have time. So we have 2 patients here with different numbers. And you can't just look at these numbers because one of them could be normal, even though you expect it to be abnormal. And one could be normal or abnormal and you expect it to be normal. So you can't just look at one thing, like patient A. What do you notice that's low? Yeah, you guys are really sleeping tonight. So this is the hemoglobin. That looks low right away, right? Patient B, everything kind of looks low except for the hemoglobin, right? So you have to go through all these steps. So in patient A, if we want to get the CaO2, the left side of the equation takes into account the hemoglobin, right? Which is 7. So patient A. Then you multiply the amount of oxygen that 1 gram of hemoglobin can carry, and that's 1.34. You memorize that. Then you multiply the SaO2, which is a decimal, 95, right? 0.95. And you add you multiply those numbers together, and you're going to get a number like 8.911. Now that is added to now the solubility in the plasma, which you take the partial pressure of oxygen, PO2 or PaO2. And that's a whole number, 85. Be careful if you listen to the Professor Liberty narrations. I picked up that she made a mistake here and she used a decimal, I think. So I changed it on there, but I didn't change the narration because I don't want her voice is so nice. I didn't want to mess with it. So, but she didn't make a mistake there. I just noticed it after 5 years. So this is a whole number. And then you multiply times the solubility coefficient, which is 0.003 milliliters of oxygen that can be dissolved in 1 deciliter of blood. And we came up with a number of 0.255. And then if we added these two numbers together, I got 9.2 milliliters, 9.2, sorry, milliliters of oxygen per deciliter of blood. And this is low because it's below 16, right? 9.2, 9.2. So patient A has a low CaO2, most likely because of the anemia. But if we did a pulse oximetry on this patient, again, they're going to have a high, they probably would have had a high, same number. But at least we found out that their CaO2, this person is in respiratory distress, most likely due to anemia. There's other things we have to take into account. Now, patient B, same thing, basically, same pathway. Normal hemoglobin amount, it's 15, right? You got the 15 grams per deciliter times that number that doesn't change, constant, 1.34 milliliters of oxygen that can be carried in 1 gram of hemoglobin times the SaO2, which in this case is 85. So that's a decimal. That's a decimal in patient B. That's the SaO2. And if you multiply those, I don't know if I got this right, but it's 12.75. So even though this person looks in numbers not looking so good, this may turn out okay. And then you go to the other side of the equation, which is your solubility of oxygen in the plasma. And you take the PaO2, which is low, right? 55 milliliters, I'm sorry, millimeters of mercury. And you multiply the solubility coefficient. And you get a number like 0.165. And if you add those together, the 0.165 plus 12.75, you get a number of 17.3. And that's normal. That's a normal CaO2. Yes. So there was a mistake on patient B. The left side of the equation with the hemoglobin carrying capacity, 0.85 times 15 And 1.34, the answer was 17.085, so it wasn't 12.75. So you added the 17.085 plus the 0.165, right? And that's what you got, right, Taylor? You got the 17.3, and that's the right answer. Cool, thank you. So that's basically it with CaO2 and pulse oximetry.